So let me please introduce Dr. Michael Howard Augenbraun. He's a professor of medicine at SUNY Downstate College of Medicine and the Division of Infectious Disease Director and Program Director. He's a long-term consultant for the New York Department of Health STD Prevention Training Center and Syphilis Education Council at the New York Department of Health AIDS Institute, and co-chair of the New York State Department of Health AIDS Institute STI Guideline Committee. We are pleased to welcome him today for his presentation, Syphilis, Reemergence of the Great Pretender. Thank you.
Thank you for inviting me. Let's see if I can do this right after that introduction. I'm going to see, share screen. And here we go. Okay, thanks to the conference organizers for inviting me. We're going to do a little brief refresher on syphilis, which is always timely, I think. Syphilis is a endlessly interesting and troublesome problem. Not only has it been recognized in Western medicine for over 500 years, but it has both acute and chronic manifestations. The chronic manifestations oddly show up oftentimes after years of latency. It abets acquisition of other infections like HIV, leads to adverse birth consequences. And despite not being part of any normal flora nor having any animal reservoir, and also despite the availability of relatively cheap, easy to administer, well-tolerated, single-dose curative therapy, it remains a public health menace. So it warrants our respect and ongoing interest. Anyway, let's see if we can go here. There we go. Sorry about that. Anyway, I have no financial affiliations to disclose. The usual learning objectives: you'll be able to describe the natural history of syphilis, initiate a diagnostic workup for syphilis, and you'll learn something about managing syphilis. This is the pathogen in question. It's a corkscrew spirochete. This is a dark field microscopy view of the organism. Dark field microscopy is something of a lost art, but can still be done on primary lesions if you have the right type of microscope available. I dare say most people don't have that available. There are three recognized treponemal pallid, pathogens in nature that are related to syphilis but are not the same thing. Those include yaws, Bajal, and Pinta. Of the three, the only one that really is relevant in the clinical universe these days is yaws. There still are episodes of yaws, cases of yaws that are described occurring in the South Pacific and in West Africa. The one problem I think this raises in terms of clinical issues for some of us, if you take care of patients occasionally from the Caribbean, as I do, some of the elderly patients may have been exposed to yaws as children many years ago before the World Health Organization embarked on an eradication program. And I'll have to say that the commonly used serologic tests for syphilis don't distinguish between yaws and syphilis, and so it can be a bit confusing. Syphilis epidemiology is an interesting story. After the introduction of penicillin right at the end of the Second World War, there was a precipitous decline in the numbers of cases of syphilis identified in the United States. And it remained somewhat stable and declining over very many years. And then in the late 1980s, there was a spike of cases, somewhat inexplicable, but attributed potentially to a underfunding of the public health sector, the AIDS epidemic, the crack epidemic, so on and so forth. And almost as precipitously and inexplicably, the case rates began to decline. We don't really know why that happened either. I think that remains something of a mystery. But at some juncture, there was so much faith that these numbers were going to continue to decline that there was a program for the national elimination of syphilis. And you almost had to know what was going to happen after that occurred. Of course, the case rates began to go up. And this is data from the New York City Department of Health. It's a little bit more granular than that other national graph is. And you can see actually that over the many years, there's actually a rise and fall in the rates in syphilis, little bumps in the graph. And there may be some element of sort of community-wide immunity that mutes some of this. And as new people enter the sexually active pool of individuals in the community, you have more people who are at risk for syphilis. That's not entirely clear, but that's what's been postulated. Here's that rise of cases in the late 80s, that precipitous decline into the 90s, almost to 2000. And here's something nobody in public health wants to see, which is a rise in the numbers of cases. Now, one of the interesting phenomena about this rise is that historically, most syphilis diagnoses have been made in the public health sector, in STD clinics run by departments of health. This latest uptick in the numbers of cases is distinctly unusual in that most of the cases seem to be identified in non-STD clinic settings. And therein, I think, is the importance of making sure that primary care doctors and people from a wide range of clinical experiences know something about syphilis, because it's not just something seen in the Department of Health clinics anymore. Here's some more interesting epidemiologic data that's in contradistinction to the data that you would have looked at maybe 30 or 40 years ago. Primarily, most of the uptick in the disease rate right now is in men who have sex with men. While there is some in men who have sex with women and some in women, the numbers are far lower, and most of the disease in men who have sex with men. And if you look at the graph here, you can see that the number of cases of men who have sex with men who are known to be HIV positive almost parallels the numbers that are HIV negative. And it leaves one to wonder what happened with all our messaging about safe sex. And as I mentioned earlier, syphilis can abet the transmission of HIV by causing disruptions in the genital epithelium, among other things. And so this is really a bad development. Not only is it a bad development that the case rates are going up, but the portion of the population that's afflicted with this right now doesn't need this issue. And as could be expected, even though we're talking about primarily a disease that's seen in the MSM population, eventually this begins to move into other portions of the population. There has been an uptick in the numbers of cases seen in women, and right behind that you can expect that you're going to see congenital syphilis cases. And this is really one of the terrible consequences of this infection. It contributes to stillbirths, prematurity, and all the various manifestations of congenital syphilis, none of which are, or very many of which are not reversible and quite debilitating. So moving on to the natural history of syphilis, I think most people have probably seen this graph, this timeline of syphilis clinical manifestations at some point in time in their career. Syphilis, like other spirochetal infections, seems to occur in stages, clinical stages. The primary lesion occurs within a few weeks to at most a month or two after exposure to the treponeme. Without any treatment, there's resolution of the primary lesion with the subsequent development of spirochetemia and the development of much more diffuse manifestations of disease, characterized perhaps most classically by the rash that we all associate with syphilis. Subsequently, this resolves as well, even if no therapy is given. People can have recurrent secondary disease within about a year to 4 years after the resolution of secondary disease. And this is the period that's regarded as early latent, before this thing can occur. And even here it resolves, and then the patients will go into a long period of latency. And it can be very variable. And in that group of people, about a third of them may go on to develop the late manifestations of syphilis that everybody is familiar with. And those include neurosyphilis, cardiovascular syphilis, and late benign or gummatous syphilis. I do want to make a distinction, though. I said neurosyphilis was a manifestation of tertiary disease. Truth be told, neurosyphilis is sort of an animal of itself. The central nervous system is invaded very early on in the development of syphilis. And in fact, about 40% of people with secondary syphilis probably have unappreciated asymptomatic neurosyphilis. And then there can be the development of a variety of manifestations of neurologic involvement throughout the course of the disease. So neurosyphilis is not purely a manifestation of tertiary disease. It needs to be understood. And here are some of the manifestations. You can have early CNS invasion. Again, the clinical implications are not clear for the vast majority of people that have that. You can have acute symptomatic meningitis. You can have asymptomatic meningitis. You can have meningovascular events. These have been well reported, and we're always reminded to be on the lookout for young people with stroke syndromes who have no business having stroke syndromes. Truth be told, is meningovascular syphilis is probably pretty rare. And then there are the classic manifestations of tertiary syphilis, general paresis, tabes dorsalis, the development of gumma potentially in the central nervous system, and also ocular and otic manifestations. And so I would say that neurosyphilis should be considered for anyone with serologic evidence of syphilis and neuropsychiatric and or ocular or otic disease. A couple of illustrations. Here's a lesion of syphilis, the primary chancre. These are indurated and non-tender. So they're a little bit like chancroid and a little bit like herpes. They don't, they're non-tender and they're indurated. Again, here's the rash of secondary syphilis. It's not a great illustration. You can see hyperpigmented lesions all over the place. There's a faint sense that there are hyperpigmented lesions on the palms of this individual. Palmar and sole rashes are supposed to be pathognomonic for this disease. Other diseases can give you rashes on the palms and the soles, but those things such as meningococcemia, Rocky Mountain spotted fever, the patients are usually quite sick. Secondary syphilis patients can be ill with fever and fatigue, but they're not that sick. By the way, these are keratinized lesions and they're not felt to be infectious. Here's somebody from our clinic with maculopapular lesions on the palms and the soles. They don't look like anything particular or specific, but they're occurring on the palms and the soles. And this individual had a highly reactive RPR, which we'll talk about. Lesions can look like a lot of things. This person may have been confused as somebody with psoriasis or eczema. And so I would offer to you that any person who reports being sexually active who has a rash of any sort for inexplicable reasons should be regarded as potentially having syphilis and need to have diagnostic tests done. These lesions are very specific. This is condylomata lata, and these are not chancres of primary syphilis, but these are rather manifestations of secondary syphilis. They occur in intertriginous areas. They may occur in the nares or in the mouth where they're known as mucus patches. Unlike the keratinized lesions I showed you before, these are highly infectious. They're full of treponines. This is believe it or not, this is an illustration from an article that appeared in the late 80s describing somebody with a primary chancre on the eye. I don't know how you get a primary chancre on the eye. I'm not sure I want to think about that, but that's what this person reportedly had. And it leads me to discuss I don't know why this, oh, here we go. Some aspect of ocular syphilis that I think are important to discuss in the current environment. Eye involvement with syphilis truthfully occurs most frequently in secondary syphilis and in late syphilis. Almost any part of the eye can be involved, apropos my illustration of the person with primary syphilis in the canthus of the eye, very unusual. The vast majority of eye problems associated with syphilis, though, are associated with many other infectious and non-infectious diseases. And so teasing out what's being caused by syphilis or being caused by these other diseases can be quite difficult. And therefore, there really are almost no eye findings that are absolutely specific for syphilis. I will say that a lot of the attention about ocular syphilis, it revolves around uveitis. And the uvea is the inner layer, the choroid and the ciliary body of the eye. And there can also be retinal nerve damage from syphilis as well. It's unclear which of either of these things is a manifestation of neurosyphilis or not, and that's a big point of contention and discussion in the syphilis clinical care community. It remains to be resolved. I bring it to your attention because of late, in the last couple of years, there have been some reports of a number of ocular syphilis cases. There were case reports that were identified, I think, in 2013-14, and subsequently the CDC identified 8 jurisdictions in the United States and went about looking to see how many of these syphilis cases reported to departments of health were associated with ocular findings. And they found a fair number of cases, almost 400 cases, total between 2014 and 15, a lot of men, a lot of MSM, a fair number of HIV positive, but that's representative, I think, of the epidemiology of the current epidemic. People were mostly quite symptomatic. Uveitis was, again, sort of the common presentation. About half and half had either a single eye or both eye involved. And where CSF results were available, a lot of folks had CSF VDRLs that were positive. Now, moving on to diagnostics, you're all familiar with the fact that traditional syphilis testing is a two-step process. We use a non-treponemal serologic test like the RPR or the VDRL, which can be quantified and rises with active disease or failed therapy, and declines with successful therapy or latency. If it's reactive, though, we never use this as the primary diagnostic tool. We do a treponemal serologic test like the FTA, the TPPA, a variety of immunoglobulin tests, EIAs, chemiluminescence tests. These are not quantifiable and they lead to lifelong reactivity. Just to make this point, I don't want you to get lost here, but most of these tests are not entirely sensitive at the earliest stages of syphilis. So if you see somebody with the either incubating, what you think is incubating syphilis, or the onset of very early primary syphilis, and their serologic tests are negative, don't bet on the serologic tests. Bet on your clinical suspicion. Repeat the test or treat the patient empirically. That's the only point I wanted to make here. Now, some people are confused by the current practice of what's referred to as a reverse algorithm. Because of low-cost automation and standardization of newly available EIA tests, a lot of labs that are involved in large-scale testing have gone to using basically the treponemal specific test as a screening test followed by the non-treponemal test. And it's problematic because what we're discovering is a lot of people who are positive on the treponemal test and not positive on the non-treponemal test. And we don't really know what to do with that. You know, these tests themselves may have false positives. They also may be reflective of old resolved disease, but we can't tell that from the tests themselves. This is the recommended approach, the algorithm by the CDC, and we follow this, and I think most people who are faced with the reverse algorithm do as well. If your EIA is reactive, you go to an RPR. If the RPR is reactive, you stage the patient and treat them by CDC Rex. If the RPR is non-reactive, then you do a second treponemal specific test, like a TPPA. If the TPPA is non-reactive, we consider the EIA probably a biologic false positive test and disregard it. If the TPPA, on the other hand, is reactive, we have two different treponemal tests that are positive, and we again try to stage the patient and treat by CDC recommendations. Here are some screening recommendations I think you should be aware of. All pregnant women should be tested at the first prenatal visit. They should be retested at 28 weeks and at delivery if they're in a high-risk area. I would say that this is probably becoming more the norm, and we're awaiting revised CDC recommendations to come out shortly. For MSM, they should be tested at least annually. If they're high risk, if they're engaging in high-risk sexual activity, retest them every 3 to 6 months. And the same applies to HIV-positive patients. If they're sexually active, test them at the first visit and annually, and more frequently if they're at high risk. Now, this is interesting data, and I'm sorry we can't really dig too much into it, but in Australia, they embarked on a very aggressive national screening program for syphilis. And the top represents people who are HIV negative, and the bottom represents people who are HIV positive. And the only point to make here is that as the years go by on the graph, the number of early syphilis cases that are identified goes up as per this line. But what you can see also is that the majority of these cases that are showing up in this screening procedure are early latent cases. And what I think this tells us is that if you have an aggressive screening program, you can identify people who have had primary and secondary disease unrecognized and have entered into some form of latency, and you can treat those patients and hopefully eliminate the risk of progression to tertiary manifestations of disease. So a program like this is actually very useful in identifying many more cases than would have been found before and leaving many people untreated in the community. Treating people is to stage them. If you can stage the disease, primary, secondary, early latent of unknown duration, or late latent, then you can easily figure out how to treat patients. And despite 30 years of going over these issues, the recommendations stand. The recommendations are applicable to pregnant women, and the recommendations are all applicable to HIV co-infected individuals. Primary, secondary, and early latent syphilis gets treated with a single injection of benzathine penicillin, 2.4 million units IM once. I mentioned the Jarisch-Herxheimer reaction in regards to secondary syphilis. It's an immune manifestation of the killing of the treponemes, presumably. I will say that there are some recommendations that women diagnosed and treated late in the pregnancy get 2 shots, but I don't think there's a lot of data to support that. For folks that have late latent or latent of unknown duration, then benzathine penicillin, again, 2.4 million units once a week for 3 weeks is recommended. And the difference here is that when they are in latency, the organisms are not replicating actively, and you need depot penicillin on board for a lot longer in order to kill slowly replicating organisms. For late tertiary syphilis, except for neurosyphilis, the recommendations are that you rule out neurosyphilis, then treat as latent syphilis if neurosyphilis is ruled out. And by this I mean cardiovascular syphilis and gummatous syphilis. Now, going back to late latent recommendations, the intervals between weekly doses optimally should be no more than 7 to 9 days. And in pregnancy, there should be no missed doses. I think all of us face this issue. Somebody embarks on a 3-week course of benzathine penicillin treatment. They miss the second shot. They show up 10 days instead of 7 days. Sometimes they show up 14 days. For many years, there probably was some element of leniency pushing it out about 2 weeks for non-immunocompromised and certainly for non-pregnant individuals. I think we've gotten a little bit more rigorous in the last few years, such that if you miss your dose by 7 days, if you go out about 9 days, it's okay. You could probably just continue on your course of therapy. But again, given the level of concern about pregnancy, the recommendations are that in pregnancy, no missed doses. If you miss your dose, you go back to 0 and start again. Pregnant women and HIV patients, as I mentioned before, get standard therapies. Alternatives to penicillin, tetracyclines, mostly doxycycline, have been recommended for years. There's a fair amount of not bad literature to support courses of therapy. It's 2 weeks for early stage disease and 4 weeks for latent disease. Ceftriaxone looks like a good drug for treponema pallidum treatment, syphilis treatment, but the dose and duration are not entirely clear. There are recommendations for daily dosing, IM dosing. The literature is much more scant for this treatment. And it's important to remember that there are no alternatives to penicillin in pregnancy, none. And there are no alternatives to penicillin in the treatment of neurosyphilis. Who needs an LP to rule out neurosyphilis? Well, I always hark back to something I was taught when I was a resident. If you think about doing an LP, then just do an LP. Don't wring your hand about it. Diagnosis of neurosyphilis requires a CSF evaluation. The current CDC STD treatment guidelines for doing an LP are here: neurologic or ophthalmic signs or symptoms, evidence of active disease, of tertiary disease, treatment failure, whatever that is actually turns out to be. And for some time, there's also been some tentative recommendations about HIV patients with high RPRs or very low CD4 counts. I'm not sure that that's entirely supported by the literature. And a diagnosis is based on findings in the CSF. Either the VDRL is positive or there's an elevated white blood cell count. You can have one or the other or both of those things, and it counts for neurosyphilis. Protein elevations don't really mean too much. FDA ABS is not really approved for this use, although some people say that it's very sensitive. And I'm not going to embark on a discussion of PCR or cytokines as alternative surrogate markers. Neurosyphilis treatment is problematic. It's 18 to 24 million units a day of IV aqueous Pen-G for 10 to 14 days. That means a patient must spend that 2 weeks in the hospital. There are alternatives, procaine pen plus probenecid as an IM injection, but everyday injections of procaine pen is strategically somewhat difficult. Ceftriaxone has been recommended to some degree, but there's not a lot of data. Doxy has good central nervous system penetration, but there's just not enough data. And the current recommendations are ocular syphilis should be treated as neurosyphilis with or without a positive CSF. LP should be done to follow up if there are abnormalities. Syphilis post-treatment follow-up for all stages. First of all, there has to be partner notification. Second of all, everybody should be HIV tested if they're being treated for syphilis. Co-infection is unfortunately common. There should be twofold declines in the non-treponemal serologic test, the RPR, over 3 to 6 months for early and 12 to 24 months in latent stages of disease. But this is a very soft finding. In fact, if you test people too soon after treatment, sometimes you'll find that the titers go up rather than down, and you may be led to overtreat patients. Some titers never go away. Some titers don't decline properly. CSF white count should resolve 3 to 6 months, and the VDRL may take a lot longer than that. And the CSF is usually normal if the RPR becomes non-reactive, and it may obviate the need for a repeat LP. And pretty much lastly, this just is a graph that shows that as we've been administering more PrEP, we've been seeing more STIs, including syphilis. So I think everybody has to be on their game about this. And with that, I'm going to finish by just showing you a picture of a statue in Verona, Italy, of the man who ostensibly named this disease. His name was Girolamo Fracastoro, and he was a physician in Renaissance Italy. And there's this statue in Verona, and he's holding an orb, and it said that if an honest man passes beneath his statue, he'll drop the orb. And you can see that 500 years later, he's still holding his orb. So be that as it may. Anyway, I thank you for your attention.
Thank you for a fabulous talk, Dr. Augenbraun. That was really terrific. We are really seeing a lot more syphilis, and looking at the audience questions, lots of questions around syphilis. So
there always are.
I'll begin. So one question is the rash of syphilis contagious?
So yeah, always a great question. I alluded to this fact. The lesions that we're familiar with of secondary syphilis on the palms and the soles are keratinized and, generally speaking, not considered infectious. But the rash that I also showed a picture of, condyloma lata, on the scrotum, and they'll occur in the anal area, in the inguinal area, and again in other manifestations in the mouth and in the nose. Those are open, moist lesions, and they're teeming with spirochetes, and those can be highly infectious.
Great, thank you. If a patient is diagnosed with clinical ocular syphilis, but has no clinical evidence of meningitis, do we have to do an LP, since we're going to treat with IV penicillin either way due to the ocular disease?
That's also a very good question, for which I'm sure there's no really good answer. You're right. If you're going to treat for neurosyphilis, the need for an LP is probably obviated. On the other hand, some clinicians would tell you it would be good to know that there are CSF abnormalities or not. And if there are, it would be nice to know that they resolve. A lot of this disease, it remains something of a mystery. And I think, again, knowing that your patient has CSF abnormalities and that with treatment those go away strikes me as being an important thing.
Great. At what time should patients with syphilis get an eye exam, even if they have no vision symptoms?
Yeah, again, very interesting and difficult question to sort of wrap your head around. I think all of us as clinicians, and I am not an ophthalmologist, obviously, should, in this day and age, pay more attention to ocular complaints and an eye exam. I mean, medical students probably don't even know what a fundoscope is anymore. So I'm not sure how talented any of us are in doing good eye exams, but we should take a minute and go over these issues. I think if the patients are clinically stable, sending the patient to an ophthalmologist is fine if you feel that that's warranted. But it's clinical judgment. I'm not sure that you have to send them to an ophthalmologist, but you should take some time, go over symptoms, look for signs. I think that behooves us all.
Okay, a few questions really around timing. So from the time of infection to clinical syndrome, and then when should we expect the RPR titer to rise or convert from non-reactive to reactive?
So as I mentioned, in incubating syphilis, certainly, and in the very earliest stages of primary syphilis, the non-treponemal test and even the treponemal tests may be falsely negative. And again, clinical decision-making trumps laboratory tests here. If you think you're dealing with somebody at risk for syphilis, hold on tight and make sure you follow up with a repeat test. I would say that if somebody has a primary lesion, within a week or so, the titer should start to rise. So, repeating that test at a weekly visit or 2 weeks later would make sense to me.
Great, terrific. That answers a few of the additional questions. Here's something an audience member said. This is a novice question. Why does syphilis present so differently in each person? My understanding of the timing of diagnosis, but a person, could they have the same time from exposure but have different symptoms?
I'm not sure I understand exactly the example being tendered, but as we like to say, neither the bugs or the people or the patients read the textbooks, so they don't know what they're supposed to do sometimes, and the staging of the disease and the timeline is really just a guideline, and people can present with varying themes around that, and so I wouldn't get too locked into it. Sometimes primary lesions are missed and patients present with secondary disease, but they probably had primary lesions, they just didn't recognize it. So there's not much to say about that. It does follow this pattern though.
Thank you. Okay, so if 40% of patients with secondary syphilis have asymptomatic neurosyphilis, would you recommend doing lumbar punctures on everyone or only if they're symptomatic? And what about specifically patients with HIV and secondary syphilis?
Yeah, that's a great question. And again, an unresolved issue. I don't think anybody is recommending that, that all patients with secondary syphilis undergo an LP. Our historical experience tells us that the treatment for secondary syphilis eliminates disease and people don't generally go on to develop neurosyphilis. So I think we can probably rest comfortably with that recommendation. The question about HIV patients is a little less clear. Early on in the HIV epidemic, there were a spate of case reports of people who didn't respond properly to therapy, people who came back with overwhelming neurosyphilis after treatment for secondary syphilis. And despite our efforts over the last 25 to 30 years to try to tease that issue out, nobody's really been able to demonstrate that HIV patients handle this problem any worse than anybody else. There's probably some immunologic response that takes care of whatever that early central nervous system invasion is. On the other hand, this may explain some of the recommendations about low CD4 counts and very high titers in HIV patients warranting CSF evaluations. And I don't think anybody would fault you for doing that. I think there's reason to suggest that that's not a bad idea. So bottom line is not everybody with secondary syphilis should get an LP if they're asymptomatic. In HIV, it might be considered in people who are severely immunocompromised.
Great, thank you. A few questions on partner treatment. If one partner tests positive for syphilis and the other negative, should I treat them both? And a related question, how do you approach a partner treatment in the later stages?
The general approach, obviously, if you have a patient in front of you who has syphilis, you suspect has syphilis, you treat that individual. Again, I mentioned that you need to do partner notification, and the way you handle that from a treatment standpoint is you test the individual. if it's been, and there are recommendations in the CDC STD treatment guidelines that I would refer you to, and I can't remember explicitly the duration, but it makes sense. If the partner had contact with somebody with early syphilis, then you treat that person right away and you do an RPR. I'm talking about the partner now, because they may have incubating syphilis, they may not come back, and the risk of transmission in the relatively recent past is high. So giving that person a shot makes sense. If the RPR comes back and is reactive, one could ask the question, is it possible that that individual has latent disease and therefore warrants multiple shots of penicillin? And that's a clinical decision-making process. I think if somebody's had contact with somebody with latent syphilis, clear latent syphilis, no evidence of early stage syphilis in the recent past, then I think you could probably just do an RPR and wait for the results to come back to make a decision. But the risk there of incubating syphilis is fairly low. I hope that answers the question.
Yes, great. Let's see, a patient is admitted with community-acquired pneumonia, concurrent diagnosis of HIV and syphilis, so not so uncommon presentation. Positive blood culture susceptible to ceftriaxone. So the patient received 14 days of IV ceftriaxone, 2 grams daily for his bacteremia. Would you give him penicillin to treat his syphilis as well?
I guess it depends. If there was early stage syphilis, I think that treatment might be reasonable, might be considered reasonable, and I would certainly simply follow the titer at that juncture. If the person had a diagnosis of latent syphilis and had just received the typical 7 days of treatment or 10 days of treatment, that Rocephin treatment may not be quite enough, again, because in latency you have to treat for a longer period of time. You might decide to give that person a shot of benzathine penicillin on the way out the door and then bring them back to clinic and give them another shot of benzathine penicillin to have antitreponemal medication on board again for over a month.
Great. So, okay, we have time for, I think, one more question.
Sure.
What are your thoughts regarding doxycycline for syphilis prophylaxis?
It gives me the willies to a certain extent. I think, using any drug for prophylaxis, runs the risk of inappropriate use, of drug resistance in the community. I know that there's some reasonable literature that supports its use to prevent syphilis and chlamydia, but I think we need more data, and I suspect that if anything, it's going to only be recommended for people at extremely high risk for contracting these STIs. So we'll have to wait and see what the data tell us.
Thanks. Lots of interest in your particular talk, and I wanted to remind everyone that there is a breakout session diagnosing and treating syphilis for your additional questions. Sorry we weren't able to get to all of those, but thank you so much, Dr. Augenbraun.